Hi, in this video let's start with cavity varnishes function. So why do we apply a cavity varnish beneath an amalgam restoration? So the objective here is to seal the dentinal tubules and to minimize pulpal irritation. And most importantly, in previous days when low copper amalgam was used, corrosion products used to form. So to prevent the entry of corrosion products into dentinal tubules and as a consequence amalgam blues, to prevent all this sequelae, we use cavity varnish, isn't it? So we'll go through some literature. In cavity varnishes, they are composed of natural gums like copal, rosins or synthetic resins which are dissolved in organic solvents like acetone, chloroform or ether. In vitro studies suggest that varnish reduces the infiltration of irritating fluids through marginal crevices and lessens pulpal irritation. Clinical observations based on tooth sensitivity as reported by patients have yet to confirm these benefits in vivo. Varnish is also claimed to prevent penetration of corrosion products of amalgam into dentinal tubules, thereby reducing unsightly tooth discoloration often associated with amalgam restorations, which is nothing but amalgam blue. However, with the use of high copper amalgam products, which are more corrosion resistant than their predecessors, they have diminished the need for varnish. And also make a note that varnish, it's not indicated or it's contraindicated underlying adhesive restorations like GICs or even under composite restorations, right? So this is some information pertaining to cavity varnishes, fluoride varnish as such. Now moving on to the next topic, glomerular filtration rate in renal failures. I guess stage 3 renal failure was asked in the recent exam. So we'll go through glomerular filtration rate in different stages of renal failure as you can see in the image. In stage 1, you can see glomerular filtration rate, GFR 90 or even higher. Stage 1 indicates kidney damage with normal kidney function. Stage 2, kidney damage with mild loss of kidney function, GFR 89 to 60. Stage 3, we have A and B subdivision. Stage 3A, mild to moderate loss of kidney function, GFR 59 to 45. Stage 3B, moderate to severe loss of kidney function, GFR 44 to 30. Whereas stage 4, severe loss of kidney function with GFR 29 to 15. And stage 5, kidney failure with GFR less than 15. And also you can see in another table, GFR, estimated GFR, average estimated GFR in different age groups. You can just make a note of it. 20 to 29 years, it's 116, 30 to 39, it's 107, 40 to 49, 99, 50 to 59, it is 93, 60 to 69 years, it's 85, above 70, it's around 75, the GFR values with respect to different age groups. Right. Now moving on to the next topic, we have discussed in detail about levels of prevention in one of the live sessions previously in YouTube, right? You can also find the same in e-classes. So screening comes under which level of prevention? As you know, we have basic, primary, secondary and tertiary prevention. Primary is an intervention implemented before there is evidence of a disease or injury. It's like preventive measures like fluorides, for example. So risk reduction is achieved in primary prevention. Whereas secondary prevention, an intervention implemented after a disease has begun. It's like interception more or less, but before the disease progresses to a symptomatic phase. So early identification, that is thorough screening and treatment, falls under secondary prevention. If you look into tertiary prevention, we have intervention implemented after disease or injury is established to prevent sequelae of a disease. You can refer the previous live session, levels of prevention. We have discussed in detail about various components of these levels of prevention. So screening falls under secondary prevention, right? Now moving on to another topic, sites for intramuscular injection in case of adults. So I'll go through some literature. So based on what kind of question was asked pertaining to this topic, I hope you can correlate. So we have different sites of intramuscular injection. Ventrogluteal, vastus lateralis and deltoid, which you're all familiar with. So ventrogluteal, as you can see in the image, ventrogluteal, the site involves gluteus medius and minimus muscle and is safest injection site for adults and children. The site provides greatest thickness of gluteal muscles, is free from penetrating nerves and blood vessels, and has a thin layer of fat. Whereas vastus lateralis, the vastus lateralis is commonly used for immunization in children from infants through toddlers. The muscle is thick, well developed. It's located on the anterolateral aspect of thigh and extends from one hand's breadth above the knee to another hand's breadth below the greater trochanter. The middle third of muscle is used for injections. The width of muscle used extends from the midline of the thigh to midline of the outer thigh. And to help the patient relax, ask the patient to lie flat with knees slightly bent or have the patient in a sitting position. And next, coming to deltoid muscle. Deltoid muscle, as you can see in the image, we have a triangular shape and is easy to locate and access compared to the other sides, but is commonly underdeveloped in adults. Begin by having the patient relax the arm. The patient can be standing, sitting or lying down. To locate the landmark for deltoid muscle, expose the upper arm and find the acromion process by palpating the bony prominence. The injection site is in the middle of the deltoid muscle, about 2.5 to 5 centimeters or 1 to 2 inches below the acromion process. To locate this area, lay 3 fingers across the deltoid muscle below the acromion process. The injection site is generally 3 finger widths below in the middle of the muscle. And also in some other literature it's mentioned that if the amount of injection that has to be given is around 1 ml or less, we prefer deltoid, but if it is more, like more volume of injection, then we go for the first discussed site, ventrogluteal, right? So this is some information pertaining to various sites for IM injection, especially in adults. And depending upon the question, let me know if the question was like on a different note. We'll update the same in the description part of this video, right? Now, moving on to next topic, incisor liability. So as you know, incisor liability, discrepancy in the widths or the sizes of the permanent and deciduous incisors, leading to this liability. So the permanent incisors are larger than deciduous incisors they replace, isn't it? This difference between the amount of space needed to accommodate permanent teeth and the amount of space available, this discrepancy is called as incisor liability. In case of maxillary arch, it is 7 mm, mandibular arch, it is 5 mm, right? Now, I'm not sure about this specific topic. There seems to be a question on basal cell carcinoma. Is it the most malignant type of BCC or aggressive type? I'm not sure of it, but I'll give you some literature. So we had different types of basal cell carcinoma, subtypes like a nodular basal cell carcinoma, pigmented basal cell carcinoma, cystic basal cell carcinoma, superficial BCC, micronodular BCC, and morpheoform and infiltrating basal cell carcinoma. So of all these types, micronodular and morpheoform, they are considered to be more aggressive in nature. It's given in Schaeffer's clearly that micronodular BCC, this is an aggressive variety, less prone to ulceration, may appear yellow-white when stretched and is firm to touch. It may have seemingly well-defined border. Whereas morpheoform and infiltrating basal cell carcinoma, these are aggressive BCC subtypes with sclerotic plaques or papules. The border is usually not well-defined and often extends well beyond clinical margins. Ulceration, bleeding and crusting are uncommon. It may be mistaken for a scar tissue. So these two types, micronodular and morpheoform and infiltrating, they are more aggressive subtypes of basal cell carcinoma. Again, let me know the question in specific. We'll update this in the description part of the video if necessary. Now, moving on to the next topic, lasers used in soft tissue surgery. You can look into the table now. We have different lasers for exclusively for soft tissue surgery because we have a classification based on their application, soft tissue as well as hard tissue, isn't it? So carbon dioxide lasers, also you can see the wavelength 10,600 nanometers. erbium YAG lasers 2,950 nanometers, erbium chromium YSGZ 2,780 nanometers. Nd:YAG lasers 1064 nanometers, diode lasers 810 to 980 nanometers, and argon lasers 457 to 502 nanometers wavelength. So these are various soft tissue lasers and their corresponding wavelengths, right? Now, moving on to the next topic. Kolben test. So it's used for assessing ductility. First of all, ductility is something, as we discussed in direct filling goal, malleability is ability to make thin sheets, whereas ductility is ability to draw thin wires. So ductility by definition represents the ability of a material to sustain a large permanent deformation under a tensile load up to the point of fracture. For example, a metal that can be drawn readily into a long thin wire is considered to be ductile. So we have different methods to assess ductility. One of the method is Kolben test. As the name itself indicates, it's done at normal temperature and we perform some bending, 90 degrees bending followed by 180 degrees bending, hence it's called as Kolben test. So this specific method of Kolben test, the material is clamped in a vise and bent around a mandrel of a specific radius. The number of bends to fracture a specific material which is being tested is counted, and the greater the number, the greater the ductility. The first bend is made at 90 degrees from vertical to horizontal, but all subsequent bends are made through angles of 180 degrees. So that's some information pertaining to Kolben test. And penultimate topic of this video, enzyme for separation of DNA strands, helicase, restriction endonuclease, reverse transcriptase, ligase, etc. If at all there are the options. See, DNA helicase is something which helps in performing the following function. Enzyme, which is responsible for separating two strands of DNA in a helix, is DNA helicase, right? So that it can be copied during DNA replication. Whereas ligase is something which binds together the breaks or nicks in DNA strand, right? So DNA helicase is an enzyme which is responsible for separating two strands of DNA helicase. Now moving on to final topic, transport of sodium and glucose. We have different types of transport. We have discussed in detail in our study club as well. So co-transport is something where one molecule carries the other molecule with the help of a carrier protein symport. So sodium co-transport, we have different types of sodium co-transport. Sodium transports other materials like amino acids, glucose, chloride, iodine, iron, urates, etc. So if you look into sodium co-transport of glucose, in fact sodium and glucose there is co-transport. One sodium ion and one glucose molecule from the ECF, extracellular fluid, bind with respect to receptor sites of carrier protein of cell membrane. Now the carrier protein undergoes, it's activated, there is conformational change and the sodium and glucose are released into cell. Sodium co-transport of glucose occurs during absorption of glucose from intestine as well as reabsorption of glucose from the renal tubule. And as we discussed, sodium co-transport is a process by which, along with sodium, another substance is transported by a carrier protein called symport. Energy for movement of sodium is achieved by breakdown of ATP, and the movement of sodium ion as such generates some energy which is required for transporting the other molecule, like for example glucose, with the help of a carrier protein called symport. So this is some information pertaining to transport of sodium and glucose, which is basically sodium co-transport, right? So these are some of the topics which I wanted to highlight in this specific video. I hope it's clear.